lens. So what happens in the lens, folks? Okay. The famous disease is cataract. Cataract is a disorder of the lens. Painless, often bilateral. Okay. Now, what you see in this picture, that is a very severe cataract. It's like very, very severe. A regular cataract, you cannot look at the patient eye and picture like that, that's an extreme condition. What is cataract? Opacification of the lens. Something is start accumulating in the lens, folks, okay? Can result in glare and decrease in vision, especially at night. I will tell you this. How do you know when somebody has a cataract? They will say, recently I have a problem driving in the night. That's how it starts with it, folks, okay? They have a hard time driving in the night and loss of red reflex because something is growing in your lens, okay? So that's cataract, folks, okay? Now, the reason for cataract, aging, tobacco smoking is one of them, alcohol overuse, excessive sunlight, all these things, but I want to highlight actually diabetes. Diabetic people will have cataract because accumulate of sorbitol. Is that clear, folks? That's it. You know, the interesting part, we see a lot of patients, they come to the doctor for cataract and then they find out they have diabetes. They didn't even know they had a diabetes, but they waited until it comes to a complication of cataract, folks, okay? Then we talked about congenital disease, classic galactosemia, galactokinase deficiency, all those things, right, that we talked. What's the treatment? Surgical removal of lens and replacement with artificial lens. It is definitely worth to watch a little YouTube video in the afternoon when you are done. It's amazing how they do the cataract surgery and put a new lens inside. It was like 10 minutes video, watch it. So that's cataract. Then we talked about lens dislocation, right? So that's, we also call ectopia lentis, displacement or malposition of lens, usually due to trauma, but may occur in other diseases. Remember, Marfan and homocystinuria? How do you differentiate? Marfan is down and in. This one is up and out. Is that clear, folks? That's the way to differentiate. Marfan, you look up and out, and homocystinuria, down and inward. That's what the dislocation, folks, okay? So that's lens disorders, folks, okay? Now let's take a look at here, aqueous humor. There's a fluid inside the eye that's responsible for intraocular pressure, what we call IOP. That fluid is called aqueous humor. Aqueous humor is produced in the posterior chamber ciliary body. You could see that here. And they travel all the way to the anterior chamber. How do they go to the anterior chamber? They go between the lens and iris. There's a small space and they go to anterior chamber. Once they go to anterior chamber, they come to the corner. There's something called canal of Schlemm, and that's how they get drained. So that's how they get drained, folks. Okay, that is a normal anatomy. Is everybody clear? Okay. Now, whenever, so that the fluid is there, right? So the fluid comes from posterior, anterior, and they get drained. That fluid in the anterior chamber maintain the intraocular pressure. Is everybody clear, folks? For whatever reason, if there's a slow in drainage, you will increase intraocular pressure. I'll be crystal clear here, folks. If the fluid cannot be drained properly, then they will back up. That gives you increased intraocular pressure. And we have a fancy word for that. That's glaucoma. Is that clear, folks? That is glaucoma. So now if I ask you the basic definition of glaucoma, you should say increase in intraocular pressure due to drainage problem. Is that clear, folks? What are the different type of drainage problem? We'll talk about it, but that's the basics, okay? Now, if you see here, that's glaucoma, increase intraocular pressure, folks, okay? Now, second, let's go back to this picture. We need to talk about something else. Now you see, there's an angle. They've drawn that here to show the angle. That angle is determined by cornea and iris, folks, okay? that is determined by cornea and iris. That's where the angle is. Now, this angle can be narrowed if this iris moves forward. Is everybody clear, folks? Imagine if this iris is moving forward. That means the angle become narrow, isn't it, folks? Because that's like an angle. This is normal. When the iris moves, it's going to become like this. Is everybody clear, folks? So the human to have a proper drainage of aqueous humor, two things is important. The canal has to be perfect, which means there is no blockage in the canal. Number two, the angle has to be perfect. Is everybody clear, folks? Are you guys following me? Now, two reasons people can get glaucoma. One, there's a blockage in the canal of Schlemm. So we call this open angle glaucoma because the angle has not changed. And on the other side, the reason, the angle changes. If the angle changes, folks, that fluid cannot get in there. Is everybody clear? If the angle is changing, the aqueous humor fluid cannot get in there. So we call that closed angle. Okay, so that's closed angle. If you see open angle glaucoma, acute closure glaucoma. Clear so far? Anybody didn't understand anything here? All right, so when the angle is open, look at this picture C. When you look at picture C, that's normal. Look at that, how nicely that angle is there. But here the angle is narrow, right? When the angle is narrow, the fluid cannot get into the canal of Schlemm to be drained, okay? So that's a problem there, folks, okay? Now, let's talk about open angle glaucoma. Anterior chamber angle is open. Most common type in the United States associated with increased resistance to aqueous humor drainage through some trabecular meshwork, folks, okay? So there's something is blocking. That's the idea. What can it block? uveitis. Okay, I'm just writing here. Uveitis is another eye condition. So what happened for that eye condition, WBC come to fight. After WBC fight, they get drained through the same canal. So, but what happens, the WBC go inside and they block the canal. Is that clear, folks? So most of the time, open angle happens due to a previous another medical condition. Is everybody clear, folks? So that's the idea, folks, okay? Now, in step one exam, they only ask about angle closure glaucoma, especially acute. Especially acute. Why do they ask that? That's a true ophthalmic emergency. Okay. Now let's talk about this, folks. This is important to kind of imagine. Okay, let's clean this up. Now, what did we say? When do we close the angle? When the iris moves forward. Is that clear, folks? So if I ask you, when do you think the iris moves forward? It has to do something with the lens. Is that clear, folks? Now, light and dark. During light, do you have a pupillary constriction or pupillary dilation? During light, what do we have? Pupillary constriction. Is everybody clear, folks? It's constriction. During dark, what happened? Pupillary dilation. Is that clear, folks? Now, I'm going to tell here the anatomy. Anytime you have a pupillary dilation, it pushes the iris forward. Push the iris forward, that can close the angle. Close the angle. Is everybody clear, folks? So how do you think the question comes? This patient went to watch a horror movie. And while she was watching the horror movie, she started getting pain in one eye and lost the vision. So why did they say horror movie? When you go to the movie theater, it's dark. And when you watch a horror movie, the horror happens in the night, so the movie background is also dark. Does that make sense, folks? So your eye is exposed to dark continuously. that causes pupillary dilation, that push the iris forward, that closes the angle. Is that clear, folks? So they give a scenario that you can understand that it causes the angle. Okay. All right, let's read here. Complete pupillary block causing abrupt angle closure, rapid increase in IOP, presents with severe eye pain, sudden vision loss, folks. Okay. Light and headaches, fixed and mid-dilated pupil and everything. Dilated pupil is the problem here. That's a true ophthalmic emergency that require immediate management to prevent. So what do you do when the patient comes? Would you do anything to cause even further dilation of the pupil? No. That's why it says mydriatic agents are contraindicated. You cannot give any medication that can further dilate the pupil. Then you are expediting their blindness. So where do you keep them? In another word, you keep them in a very bright place. You keep them in a very bright place when they're bright, pupillary constriction. So that should be helping. Is everybody clear, folks? Until the surgery is done. So that's acute angle closure glaucoma, folks. And whatever I explained, it's in here, folks. Okay. Now, is everybody clear with this? So one thing to keep in mind, you never put a patient on dilation on. You don't do anything to do dilation, folks. Are we clear? All right. That's one of the good examples. Most of the ophthalmic clinics are very bright. They never keep it in a darker place, folks, because most of the patients who comes there are coming with this kind of issues. Okay. So that's acute closure glaucoma, folks. Okay. Now,
Dr. Roy, does it happen in one eye or both eyes?
Unilateral most of the time. One eye. One eye. Okay. So that's the idea. Okay. Now, let's go back here. Some other retinal disorders. Yeah. Okay. First one, here, let me highlight the high yield. Okay. These are all important, folks, but we're going to go through all of them. Let's start with age-related macular degeneration. That's a degeneration of the macula, central area of the retina, loss of central vision. There are two types, dry and wet. Dry is the most common, gradual decrease in vision with some deposits in there. Wet is rapid decrease in vision due to bleeding and stuff. The macular degeneration people, you see it in diabetic people and everybody. It gives you a permanent blindness at one day. Okay, it gives you a permanent blindness, folks. These are the people who had a diabetes that they never care about it, they never controlled it. Okay. The main reason for blindness, neovascularization. That means due to damage inside the eye, they are forming neovascularization, folks. How do you prevent that? These people need, what causes angiogenesis, if you remember from the pathology first day? Fibroblast growth factor, platelet-derived growth factor, all those things, remember? All those growth factor. They need to get an injection or anti-growth factor. So all this, okay? We need to prevent the neovascularization. Now, let me be clear. You cannot cure this problem. Once they develop, they get it. Is everybody clear, folks? But we could keep it in one level for a longer period without being blind. Is everybody clear, folks? Now, you know what needs to be done? They need to be an injection in their eye once a month. They have to get an injection inside the eye once a month. And I know a person who has macular degeneration in both of their eyes. So they get 2 injections in each eye, folks. They don't do it on the same day. They do 1 injection in one day. that after injection, they suffer for 3-4 days to recover from that injection. It hurts so badly. Okay. And let's say this week they go get injection in one eye, they rest for 2 weeks, they get the injection on this eye. Then they rest for 2 weeks, 1 month is done, they get the injection on this eye. They rest for 2 weeks, the second injection, which means every 2 weeks they have one injection in their life. So there's no break in between. Does that make sense, folks? That pain after getting injection of 2-3 days, they have to go through it throughout their life. And every month they need to get until they die. If they stop, it progress. So what this injection is doing, it's arresting right there. Does that make sense, folks? So we are not curing, we are preventing that. That one injection per eye costs us $4,000. Damn, right? So this particular guy needs $8,000 a month for both injection. So they need $88,000 a year to pay. So they better have a good insurance, if not, kaput. Okay, so that's the idea. I mean, it is, nobody will pay $88,000 for one injection. And think about the other complication. If somebody has macular degeneration, they have peripheral neuropathy, cataract, everything, because these are uncontrolled diabetic people. Does that make sense, folks? That's sad, folks. You know, the reason I'm talking about this particular patient, that particular patient cannot stop working from union because only union insurance will cover 100% for that particular time. I feel bad. The person has to still work, but they say that if they stop working, no insurance. Does that make sense, folks? Sometimes you could get a private insurance, but then you still have to pay 30%, 40%. We'll talk about on the ethics. Still, 30% of 88,000, that's a lot of money, isn't it, folks? So they have to get that injection every month, okay? Now, next, diabetic retinopathy. We talked about it, right? Chronic hyperglycemia gives you increased permeability and occlusion of the retinal vessels. They have a non-proliferative and proliferative. This is mild, this is severe, okay? So if they identify early, you see, all these problems can be controlled by a single blood test of glucose and you control your glucose. Does that make sense, folks? Sometimes do you really feel bad for them? No, I don't. I have no mercy for them. You could think I'm a cold heart person. I was like, well, if you have a diabetes and if the doctor tells you you need to control the glucose. For people to develop all these complications, folks, they have more than 10 years of diabetes that's uncontrolled. Does that make sense, folks? Some people think, you know, they are a patient, they think the doctors are stupid. They could tell whatever they want, right? I've met people, they said, you're a doctor, keep it with you. I'm not going to listen. And then they come with these things. And I said, you know what? I have no mercy. Let me eat my lunch, then I'll see it. I have to eat my food, right? So the idea is, folks, I don't feel bad for these people. I don't. Okay. They come. You know, if they say that the ear is hurting, I said, I give a free tissue. You could wipe it. That's all I could tell, right? So that's diabetic retinopathy, folks, because it's all started with simple blood glucose check. I know you guys are like cursing at me, but that's what it is. You will learn automatically, folks. You know? All right. One doctor told, one patient told me, you're not a god, go to hell. When I told him you need to control, and there are people get mad. I said, I don't think I'll go to hell. Even if I do, I wouldn't know. I don't care, right? But so then, he told me, and I didn't want to say anything. You can't say anything back. And but I was telling my nurse, whether I go to hell or not, he will be living a hell life while he's alive if he doesn't take care of that. Does that make sense, folks? It's better to go to hell after you die, but not while you live. That's even more painful. Next, hypertensive retinopathy. Simply when hypertension is out of the control. High blood pressure goes into the eye and they start bleeding, folks. Okay, that's the idea. Papilledema and all these things. Okay, we talked about it. Papilledema. What is hypertensive emergency? You have a high blood pressure with endocrine damage, isn't it, folks? And at that time, I mentioned you cannot diagnose hypertensive emergency or malignant hypertension. Both are same without papilledema. You must have papilledema to diagnose that, folks. Okay. Next, retinal artery occlusion. One of the famous question comes, how do you differentiate the occlusion of retinal artery versus retinal vein? Easy to differentiate. Let's see how. When you have a retinal artery occlusion, you have vision loss. Where is it? Because it makes sense, because arterial blood carries see blockage of central or branch retinal artery, usually due to embolism. And you should know retinal artery is end organ. What does that mean? Only one artery. There's no collateral circulation, folks. Okay. Less commonly due to giant cell arteritis, but presents with acute painless monocular vision loss. You should know that it's painless, not like glaucoma, painful. This is painless. Fundoscopy will show cloudy retina with cherry red spot. See, cherry red spot is a non-specific word. How many lysosomal storage has that, right? So I wouldn't worry about that. Now let's talk about retinal vein. Central retinal vein occlusion is due to thrombosis. Now the key is, maybe it's not here. You should write it down, no vision loss. That's a differentiating factor because it's a venous blood. We have no problem with that. So no vision loss. Some retinal hemorrhage, which underline the word venous engorgement. What does that mean? The vein walls are thin, so when the venous blood is backing up, it becomes engorged, like a tortuous, because of the weak wall, folks, okay? But other than that, there's nothing. So the vision loss is one of the most important to differentiate arterial block from the venous blood. Is everybody clear, folks? Okay, so that's artery and vein. Now let's look at the next one. Retinal detachment. When you say retinal detachment, there is a layer in retina. Separation of neurosensory retina from underlying retinal epithelium. That's the idea. Now, the minute a patient comes to you, what do you think the symptom? They say they see a floater, something in their eye. The floater is the key buzzword, folks, okay? The minute they see that, you are like retinal detachment. The second question should be, did you have any eye surgery recently? Because most of the time, retinal detachment tend to be happening right after another eye procedure, okay? It's not that doctor made a mistake. Don't think like that. One eye surgery can lead a retinal detachment. Is that clear, folks? So that's no matter how, all the ophthalmologists are best, folks, okay? Sometimes people ask me, how do I find the best eye doctor? Ophthalmologists are like a filtered, the top-notch doctors, because they are the top pickup residency. That's the #1 residency in the United States, folks. Okay. They say they don't look at the application if you have in step 2 CK less than 260. They don't even open the application. And then they do that. So 1 or 2 residents per university they pick. So imagine how much filtering. In that, after they become an ophthalmologist, they do a fellowship to become a retinal specialist, folks. That retinal fellowship is only offered in the United States. It's like 5 universities, Johns Hopkins, Mayo Clinic, and all these things. So when you ever meet a retinal specialist, you shouldn't even worry, are they good or not? They're like the top in the country. Does that make sense, folks? The whole Illinois has like 3 or 5 retinal specialists. That's it. That's why getting an appointment is so hard, because they don't have many, okay? So they do those kind of surgeries, so the margin of error is 0. They won't make that mistakes, folks. So they come, so whenever they have, it's also surgical emergency. Look at that. They need to do a surgery to fix it right away. If not, they lose the vision, folks, permanently. Yeah. We don't have to know too much about retinal detachment. It's all subspecialty. Just know floaters, and then we need to fix it, folks. Okay, that's the idea. Papilledema, we just talked about it. You needed to diagnose for malignant hypertension or hypertensive emergency, folks. Okay, that's the idea. What is papilledema? When the pressure is high, you have an optic disc swelling, folks. Okay, it's usually bilateral, because when the pressure is high, you can't just select one artery, not the other. So it goes to both eyes, folks. Okay, that's papilledema here. All right, let's continue. When it comes to loss of red reflex, what does that mean? In newborns, we should be able to see the red reflex. If you cannot, that means something else is growing and blocking that. It is retinoblastoma until proven otherwise. If you cannot see the red reflex, that is retinoblastoma, folks. Simple. uveitis is an eye infection or disease, and the problem of uvea and iritis and all these things. The only thing I would remember, this can give a complication. This can give a complication of open angle glaucoma. Open angle glaucoma can be a complication of uveitis. See, what we have done, these are very basic diseases of eye, folks, okay? Now let's get into some anatomy, and we need to talk about more here. Let's do eye reflex today, okay? Now for this, I don't like the drawing. Let's draw. You could start drawing. Yeah, one is bigger than the other, but it's okay. Okay. Now, this is the right eye, left eye. Now, let me explain one, and then you could draw so you know what you are doing. Okay. So what happens is, any sensation in the eye is carried via optic nerve, because optic nerve is a sensory nerve. It's a clear fox. They carry everything to a nucleus called pretectal nucleus. Pretectal nucleus, okay? Watch me, guys, otherwise you will miss it. From pretectal nucleus, they connect ipsilateral, same side and opposite side nucleus called Edinger-Westphal nucleus, okay? You have the spelling in the book, don't worry. Edinger-Westphal nucleus. From Edinger-Westphal nucleus, you start the other cranial nerve going to the eye. That's your cranial nerve number 3, okay? So we call optic is AFF, cranial nerve number 3 is EFF, responding back to the eye. Is everybody clear, folks? Same thing on the other side. They connect to this, they connect to this. But have you noticed it? Pretectal can communicate to Edinger-Westphal on the same side and opposite side, but pretectal will never communicate with the opposite side pretectal. Is that clear, folks? All right. Go write this down and then we'll continue. All good, folks? All right. So let's see what's happening here. Don't write anything down. I'm going to explain a simple thing. Once you understand, you have no problem in life. So what we're going to talk about is a light reflex here, folks. Okay. Now, what is a light reflex? Let's say I shine the light on a patient's right eye. Okay. We put a light on the right eye. That sensation is carried to the pretectal nucleus through a nerve. You should know what that nerve is. It's optic nerve. What that optic nerve does from pretectal, it's connected to the ipsilateral same side heading a westbound and opposite side heading a westbound. So the response should be constriction of the pupil after we put the light. So as soon as I put the light on the right side, I would see the right side constriction of the pupil. Is everybody clear, folks? That's a normal finding. But that not only that, I would also see opposite side. I also constricting the pupil because why? The pretectal not only connecting the same side, but they also connecting to the opposite side, isn't it, folks? So when I put a light on the right side, if a patient is constricting pupil on the same side and also the opposite side, we call it consensual reflex. Is that clear, folks? That is the key. So when we do the light reflex, you should always look at the same eye and also the opposite eye to see if they constrict. Everybody clear, folks? So that's why we need to know this drawing. Everybody clear, folks? So if I put a light on the left side, I will constrict the left eye and also right eye. Are we good, folks? That's a normal anatomy. Now, diseases. Okay. So imagine a patient comes. So I'm telling them light is given to the right eye. The light is given to the right eye. Okay. Left eye is constricted. Left eye is constricting. Right eye is not. Where is the problem? I put the light on the right eye. Left eye, people is constricting, but the right eye is not. So where is the problem? Well, this is unique to problem. Two problem. If you should answer, otherwise it says that you don't understand this drawing. Now what you are saying is, if I put a light here, how come left side is constricting, not the right side? So let's rule out. The minute I put a light, if the left side is constricting, the optic nerve is good, the pretectal nerve is good because they are carrying the information to go to the opposite side, isn't it, folks? So the problem has to be either the right side getting the small nucleus or right side cranial number that gets the sensation. Does that make sense? Now, what if I tell you it is almost impossible to get any of these spontaneous lesions? Then the answer should be right cranial number 3. Does that make sense, folks? How do I confirm that that's the right answer? I would apply light to this side. For this patient, I will put a light on the left eye. I will only see the left eye constriction, not the right eye constriction. So you should always do more eye confirm decision. Everybody clear? So when you become a ophthalmologist, you learn about lesions and pretectal. For USMLE, the lesions will be only optic nerve or ophthalmologist. Okay, now those are the two that can be a problem. Is everybody clear, folks? So forget about it, clear. Okay, so let's do one more problem. I put a light on the left eye. I put a light on the left eye. No constriction on both eyes. But the minute I put a light on the right eye, both constricted. Where is the problem? So I repeat, I put a light on the left side, no response. I put a light on the right, both constricted. Where is the problem? I said, don't bring attention to it. Talking about this, folks, you guys are not ophthalmologists at this point. So only ophthalmologists can talk about tight ophthalmology as well. So where is the problem? So I repeat, I put a line on the left eye, no response at all, but when I put on the right side, both of them have a restriction. The answer is left side optic nerve is the problem because it's not carrying anything. Okay. So how do I know? Because when I put on the right side, both of them are restricting. So both cranial nerve number 3 is working. Only 2 is not working on the left side. Everybody clear? Anybody understand this? Good. All right. That's basically here what we talked about. So the same diagram that's explained. I just wanted to simplify. If you understand that, you could keep that away. Don't really clear, folks. All right. Horner syndrome is a sympathetic problem. We go through it. Again, anatomy of the eye muscles. You should know that. Let's go here, folks. Oh. Let's try it here. Let's see. I'm going to stop. I don't want to stop. If I stop, I cannot stop. Okay. So we're going to stop at this place. We review everything what we have done in neuro. So we are only left with these two because once I start with this cranial nerve lesion, I have to go all the way here. Okay. So what we will do on Monday, we're going to finish the rest of the eye. Okay. And I'm not counting what we did yesterday. So on Monday, we should be able to finish this and the brain stimulations. Okay. Perfect. So we will finish that on Monday, neuro, and then talk about the 2 days for that. So we should be able to finish everything by Wednesday, and we should be done.
So, the light feedback, what I'm just confused at, how do I know if it's optic nerve or if it's cranial nerve?
That's why you check on both eyes.
Yeah, so like on your last example, you said both eyes were not consistent, but if you put it on one side.
Okay, so let's do this. I'm putting a light on my left eye. I don't see a constriction on the same side or both sides. Okay, so that at this point it could be a problem with the same eye optic nerve or both cranial nerve number 3, which is not that easy to get it. So what I'm going to do, I'm going to put a light on this side now. When I put a light on this side, the same eye will constrict and the opposite eye also will constrict. So that tells you the problem of the left optic nerve that didn't carry the sensory to the predictor. Look at this diagram. So I will apply the same thing on this book. I put a light here. No response. Make sense? But the minute I put a light on the right side, this is constricting, that means this is working. This is also constricting, that means this is working. And also it went there, so this is also working. The only thing we didn't work out this time is the optic nerve on the left side.
So answer to this would be the opposite side of optic nerve.
Whatever the side you send it didn't work. That will be the side.
Okay.
Because when I put it on the left side, I didn't see a response. That means from the left side, nobody is carrying the signal. That's a problem.
Okay.
All right.
Thank you.
No problem. And tomorrow, I would suggest homework. I forgot about that. You have to learn cranial nerves. I would not teach you cranial nerves, folks. Okay, these are fundamental. You should know by now. If you don't know, don't tell me. Learn it tomorrow. Okay. Because it's very hard to do that because we have a lot to carry. So your homework is cranial nerves. It's not even hard, folks. You know, the easy way to remember, right? How do you remember cranial nerves? Okay. You have a brainstem. What are the brainstem? Midbrain, pons, and medulla oblongata. Midbrain has cranial nerve number 3 and 4. And then you have a pons. How many letters is in the pons? 4, P-O-N-S, 4, right? The next 4 cranial nerves. That's all it is. So 3, 4, midbrain, 5, 6, 7, 8 pons, 9, 10, 11, 12, medulla oblongata, that's all. But don't you wonder what happened to 1 and 2? They are way up in the brain. 1 and 2 doesn't come from brainstem. They are all the way in the brain extension. Remember, olfactory and optic nerve is way higher. That's here. We are talking about the cranial nerve there, right? This is a must. You need to know what cranial nerve comes from where and what's their function, okay? So you have to learn simply. It's either sensory, motor, or mixed, or it has parasympathetic. Second thing you need to learn, circle of Willis. I will show you the picture. If you learn this, brainstem lesion will be very easy and you will enjoy as we go through. You have here too, you could see circle of Willis artery, nicely given here. Look at this, guys. This is your basilar artery, right? How do we form basilar artery? Can you guys tell me quickly? Talk. Somebody talk. Unmute and talk.
The 2 vertebral arteries combined.
2 vertebral arteries, very good. How does vertebral artery travels?
From the internals, carotid.
Internal carotid, no. So the question is, where does vertebral artery originate from?
Is it the basilar artery or no?
Vertebral artery joined together forms basilar artery. That's what it shows here. My question is, where are you getting the vertebral artery from?
Subclavian artery.
Good job, subclavian artery. It's a branch of subclavian artery. Now, how does it travel from subclavian to the brain? There is a special location it traveled through that. I talked about it, showed you guys the picture.
Those little foramen in the cervical spine.
What is it called?
Can't remember.
Transverse foramina. Transverse foramina, it travels through that, right? That's vertebral artery. And that's, you could see, and that's a posterior circulation. And then you have anterior circulation. You need to know that what artery comes from there, folks, okay? Now, look at this. That's another beautiful circle of Willis. They have 2 colors. This is posterior circulation. This is anterior circulation. They're giving it nicely, folks. So your homework tomorrow is to review cranial nerve and circle of Willis. Okay. So if you do that, then the brainstem, you will understand when I teach rather than listening. Right? Very important. Any questions for me? Almost, we are, next week we will be done. And then I tell the students the real showtime starts for you guys next week. Right? You guys gonna start UWorld, and then NBM is coming soon. So that's where, this 6 weeks is not the stressful time. The stressful actually starts when you start the UWorld. Right? And then you have to do, and RA students is like right